Welcome to Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our goal is to provide a platform where we can educate, advocate, and inspire women leaders to lift as they rise. With every episode, you'll hear from her as we showcase the perspectives, insights, and experiences of women who are leading the way in advancing women's health and empowering the next generation of women in healthcare.
Hi, everybody. Welcome to today's episode in Season 2 of our Women in Healthcare Leadership Series. I'm Holly Kedkota, Vice President of Strategic Partnerships and Public Health at Medscape Education. Through our work in women's health and in convening our new Innovations in Women's Health Coalition, I was provided the opportunity to connect with our esteemed panelists today. Joining us is Dr. Jody Abbott. She is the Director of Obstetrics and Gynecology and a physician in maternal fetal medicine at Boston Medical Center. She is the Medical Director of the Education Center, Curriculum and Outreach for the American Medical Association. Welcome, Dr. Abbott.
Thank you.
And now we'd like to introduce Dr. Jane Delgado. She is the President and CEO of the National Alliance for Hispanic Health. Welcome, Jane.
Good to be with you.
Today, we're going to be discussing a really important topic, disparities in women's healthcare. But before we dive in, I'd like to ask our guest speakers to share a little bit about themselves, their background, and how they became involved in medicine and healthcare. Dr. Abbott, Jody, let's start with you.
Thank you so much. So my involvement in women's health has been throughout my career. I'm an OBGYN, as you said, in maternal fetal medicine. But for me, it really goes back farther because my mother had a lot of pregnancy complications and losses. And so even going into throughout my life, I've been aware of the challenges that there are for equity and just the severe disparities often in addressing priorities in women's health. During my career for the past 15 to 20 years, I've focused on reducing disparities, particularly between outcomes between Black women and white women, because in the clinical setting where I've been during that time, Boston Medical Center is a safety net hospital, and we mimic the rest of the country with these profound disparities. And one of the most disheartening elements of that is that in the past 15 years, the maternal mortality rate has been rising for all women, but particularly distinctively so for Black women. And we've, gotten through this point. So we've worked really tirelessly with our organization, with our community. But I think that, we're a mirror of the national situation that we have. And so we really have been testing in a lot of ways the opportunities that we have to improve outcomes.
It's an incredible journey, Jody. Jane, how about you? How did you land where you are right now?
I would like to say that I had a plan of what I was going to do, but actually I didn't. I think part of it is the many women in my life have had a huge impact on where I ended up, from my mother, who was a strong force, to my fifth grade teacher, who told me that I should be a psychologist, even though I had no idea what that was. And then when I was in graduate school, I went and I was going for my doctorate, and I realized that one-to-one therapy was great, but it wasn't the end-all and be-all. There's a lot of issues that people have. Then I ended up working for, under the Carter administration, and later for Margaret Heckler, who was the secretary who was very big on women's health, AIDS, and also Black and minority health. And the reason I ended up where I am was because Margaret came to me and said, Jane, you need to go and head up this organization. And I thought that she was trying to get rid of me because I was a civil servant and not a political appointee. And she was a Republican, and everyone knew I had come under a Democratic administration. And she said, no, you've got to take it because women don't get to lead. You got to go there. And I went. I promised them 2 to 4 years at the most, but I'm still here. So fighting the good fight and continuing everything I've learned from all the wonderful women in my life who have really formed and framed everything I do.
It's amazing that you both had such great inspirations and mentors. I would love to be able to explore that a little bit more, how those individuals were able to help lift you and bring you to where you are. But let's talk a little bit now about our actual topic of the day, which is about, addressing these disparities in women. I wanted to just start with some statistics about women's healthcare in the United States and have you react to this. So according to Kaiser Family Foundation's 2022 report, 18% of all women ages 18 and older reported fair or poor health status in the US. And then when you drill down by race and ethnicity, that represents 31% of American Indian and Alaskan Native women, 25% of Hispanic women, 23% of Black women, 16% of white women, 10% of Asian, Native Hawaiian, and other Pacific Islander women. Along these lines, 10% of all women 18 and older did not see a doctor in the United States due to cost. So that's, again, we're looking at 20% of Hispanic women where cost has impacted access to care, 16% of American Indian, Alaskan Native women, 13% of Black women, and 8% each of Asian and white women. When you consider that the population of women in the U.S. represents about 168 million individuals, and the important role of women in today's society, these percentages are significant. What do you think are the challenges women face today in obtaining quality healthcare in the U.S.? Jane, I'm going to ask you what your thoughts are at this point.
Well, first of all, I would say those numbers underestimate the severity of the problem for women. A lot of women just suck it up and don't say that they're having a hard time or anything. So the ones who at least say, well, I'm not feeling so good, they're ahead of the game. So I think that is actually the numbers that you got were probably not reflective of how women feel about their health. But a lot of women push forward because they have to. And it's a very different mindset than I see with the men that I also see as patients. So that's one thing. But I think that the idea of access, it's not just being able to pay for it, but once you get in through the door, does the person that you see hear you? Does that person have the tools to understand women's health? There are a lot of barriers. Access means not just access to insurance. It means once you get in the door, are you getting the care you need? And does the healthcare provider have the tools and information that they need?
I think that those are completely valid points. And I see you nodding your head, listeners. Jody's agreeing with these points. What do you think, Jody?
Well, I think, and thank you, Jane, for bringing up all of those points. I think that the healthcare system has been focused on disease management for most of its existence and most of the funding and reimbursement. So the money flows from disease management, not from health. And again, this feeds into, Jane's comment, does that healthcare provider have the tools necessary to understand what you need to be healthy? What are the barriers that you are currently facing to health? And do they have time to talk to you about health? Or as you're there to try to feel better, they're there to cross bad diseases off a list. And so we have this mismatch then between the hopes and expectations of many people who enter the system and the training, as Jane points out, the resources and the perspective of that healthcare provider. In addition to the fact that, as we know, women are for all of the other barriers that may be faced by people by their ethnicity, their age, we know women are much less likely to be listened to with every complaint that they have, and therefore they're underdiagnosed and undertreated for most conditions.
Yeah, I mean, these situations and the barriers that you're mentioning are huge challenges, and they're major undertakings that the U.S. healthcare system has to try to address. What do you think? What are you doing within your role of your institution to help try to address these barriers? Jody, you want to take the start here?
Okay, well, I'll start. I want to say I have dual roles as a clinician at Boston Medical Center and as the director of education for the American Medical Association. So I'll start first from the clinical standpoint. I'm privileged enough to work for an ACO, an accountable care organization. So the difference between that system And other insurance-based systems or traditional, perhaps fee-for-service, means that our organization is set up to have a certain amount of money every year to keep people healthy, as opposed to receiving money for how much time they spend in the hospital because of certain diagnoses. And when we switched to that, it really opened this door wide to physicians who desired and healthcare providers who desired to widen their team, for example, to include non-physician team members, to bring those people into the team and to be able to focus on initiatives that can improve health and not just those that identify complications. And so organizationally, there's been a very large investment in the community and in sort of, I would say, non-traditional mechanisms of healthcare, such as doulas, for example. So at Boston Medical Center, we've had a doula program who are birth attendants who are not physicians, not nurses. In our community, we have a very multicultural community that our hospital serves. And so we have doulas who represent the women in the communities that our patients come from, who are multilingual and are able to then have a person connected to them who is, in addition to, sort of that traditional mother or auntie figure, is also someone who knows how a hospital works for people who are attending for the first time. And so I think there's an important investment that needs to be made to have those conditions to addressing those elements that help keep people healthy. And then through the American Medical Association and the education we provide, there's been a lot of investment in helping prevent diseases such as complications of hypertension and prediabetes that could lead to other complications, and working to educate the entire healthcare team, physicians, nurses, medical assistants, and of course the public, so that everyone understands what these priorities are and to engage people in their own care.
That's fascinating. And just another point, because you have that dual role, are you able to adopt any of or share any of the practices from your role in Boston with the greater medical association through the education hub at the AMA?
Yeah, we've had a lot of, that was certainly my hope when I came to the AMA. And the AMA has been invested well before I came, particularly in the management of high blood pressure and hypertension. And with the, I would say, the spreading of that impact. So it's affected and improved the health of a very large number of people. I think it's around 5 million have been impacted so far by engaging patients in what's called the MAP program. It's about measuring BP, acting on elevated blood pressures, and then engaging patients in their care, particularly with self-monitored blood pressures. At Boston Medical Center, we've had a self-monitoring blood pressure program for our pregnant patients and for the patients after delivery with high blood pressure. And we are at the AMA through the Improving Health Outcomes group and the MAP program, working to integrate postpartum programs that will help guide the transitions of care that happen when women after delivery leave their obstetric care providers, unless they're lucky enough to have family medicine providers who've been taking care of them and their babies. Most women in America do have to transition to other providers for their care. And that's been a big source of the gaps that lead to serious complications for women, that they don't know who to call or they don't call anyone. And so working with these transitions of care for women after delivery is another way of helping empower women, that there isn't this distinct, not just a gap, it's more like the Grand Canyon between, like, there's pregnancy care and then there's the rest of your life. But of course, for women, it's all integrated together. You aren't a different person before you have a baby and after and during. This is about the arc of your health throughout your life. And that hasn't been and isn't currently in the U.S. well integrated, and we're working to do that. And I think that we need collaborators outside of OBGYN and outside of the healthcare system to be able to do that effectively.
It's amazing. Jane, how about you? What about in your role at the National Alliance for Hispanic Health? How are you helping to address some of these barriers and women's healthcare?
Well, I think there is, first of all, our mission at the Alliance is best health for all using the Hispanic experience. And the reason that we use the Hispanic experience because we know that Hispanics have all sorts of systemic issues that prevent care, but in fact we live longer than non-Hispanic whites, have less heart disease, and have many powerful things that are good, and we need to bring this to the broader community. So that means when it comes to women's health in particular, one area we work with is improving the science. So we're very involved in trying to get clinical trials to have adequate women representation and women by race, ethnicity, and whatever other factors are relevant. So we're very much active in all those discussions. We're also concerned about the policies which disproportionately affect women. So, for example, personal care products for many years had no regulation by the FDA. And we've been very active in making sure that a lot of these, like hair treatments and products that women use, and particularly lower and modest income women, use products that have chemicals that are harmful for them. So we have supported FDA getting authority to regulate these items and also pull them off the shelf. For many years, women were out getting these Brazilian blowouts or using hair products that we knew were very bad for their health, and we FDA could not do anything. So in policy, we do things like that, but also to talk to women about their total health. Jody made a very good point. We talk about women to women about how do you take care of yourself. It's not just about when you're pregnant. There's a lot of focus on when women are pregnant and babies, but the rest of their lives are totally ignored. So we've developed materials to teach women to see their body as a system, how everything interacts, and how everything you do, what you eat, what you breathe, your mood, all affects your health. So I think that it's not any one thing that we do, but it's the totality of hitting our health enterprise at many different levels to really change not just how the system includes women in every place from researcher to clinician to participant, but also how women approach that system. So we work on both ends of the spectrum. And right now we've trained, over 640 community health workers who are out there training women on how to take care of themselves. And we offer all these materials free online also.
I was hoping that you were going to mention your efforts in the community, as Jody had. Would you be able to elaborate a little bit more about how long it took for you to establish the training sessions for the community workers and how integral they are in being able to be successful in the community?
Well, to be honest, it took forever to try to get funding because everybody wants you to focus on a disease, whatever disease they're focused on. But we really wanted to look at or to focus on pregnancy. We wanted to focus on women throughout their lifespan. So trying to get funding to do it was the biggest obstacle. We finally got it, we did it. But once we knew that we had that freedom, we convened a panel of leading women from physicians, nurse practitioners, nurses, public health women, all together to come up with what did women want to hear. So we went out and asked what the women wanted to hear. We listened to them, and then we developed these materials. And we've been training women now throughout the country. And it's very exciting because some of these women who are out there in the community said, no one ever talked to me like this. And like this means we talk to them. The program is called Mi Hermana, which means my sister, which is talking women to women about the things that they may not talk about, heart disease, cancer, what is this whole thing about the immune system? Do I really need vaccines? Giving them the information so they know, hey, smoking is bad. It's not just about your lungs. It's about your whole body. This is the way your heart and lungs work together. So it's really very exciting. We have all these statements that the women have written back, and it's been great to hear their voices. But it also means that we have to look at the whole person, which is what Jody's saying, looking at the whole lifespan, and forget about older women. If you're over 65, most of the research doesn't even include you. Everyone's talking about Alzheimer's, but how much of that research really includes women? People talk about traumatic brain injury, but a lot of that research doesn't include women, and women, because of domestic violence, suffer a lot of TBIs, but those data aren't included. So there's a lot of work to be done. And I'm glad that there is now a new generation of younger women who are very excited about moving forward with their health in different ways than in the past.
I agree with you about everything that you've just said. I think it's amazing that you've been able to obtain the funding finally to train the women in the community. But you mentioned something else that I'd like to talk a little bit more about, which is the policy aspect of how do we, from a policy standpoint, start to make those inroads and those changes. And so you both have such prominent and esteemed positions. What are your thoughts about the policy element?
I'd say we have to find the allies. And unfortunately, just because a woman is in a position of power doesn't mean that she may support some of the things that we're talking about. I say some people suffer in psychology, we call it identification with the aggressor. So rather than supporting women, they support whoever's in power. So I think part of it is getting women into places where they can make the decisions, make sure that we're included, that our issues are at the forefront, but also to see who are really our allies. I can tell you a short story. I was on a board. I was trying to get it so that 1/3 of the people that we would fund on their boards, they had to have at least a third women. And even though I counted my noses and I assumed all the women on the board would vote for me, vote for this idea, but I didn't get it because some of the women were the women that they wanted to be the only ones. So, so I think part of it is we have to find who our allies are. There are a lot of men who support us, and we have to give them the support that they need so they can also join us. And there's a lot of women who don't support us. So, it doesn't, you can't look at someone and know, well, they're going to support me or they're really going to care about women's health. No, some people don't, even though they're women.
Well, I guess one of the things I was thinking about in the optimistic vein that I just heard today, we have at the AMA, obviously, is an advocacy organization that develops advocacy around policies. And there has been a lot of work done around the maternal health crisis. As I was saying, maternal mortality is rising. But the good news that I just heard today is that they just formed a bipartisan maternal health council in the Senate. So, up until now, it had only been Democratic legislators who had been on that council. And I think that's so important because as we're talking about, Jane, I was just thinking about as Jane's like, you have to find some allies. We really have to have people, regardless of, how we see their gender, how they identify, help us recognize that there is this crisis going on and that there is legislation that can help support improved outcomes by, for example, funding for 1 year of postpartum care, which all of the organizations that I'm associated with are in favor of and got very close to passing, but didn't pass. But again, now that there's a bipartisan group, maybe that will have an opportunity because I think that care, that bridge care for women after pregnancy to be able to follow up, to maintain and recognize that this is an important health issue for the rest of their lives, to be healthy moms and to maintain their health, to care for their families, is a really strong motivator for women. But if they don't have access because of their insurance, let alone we have a primary care provider crisis in America, we really want to be able to provide the resources and to bring people together on that, because we have to recognize the causes behind so many of these barriers to care. And with the Black maternal health crisis, we recognize that this is a multifactorial problem, that some of it is women in rural areas, some of it is women in hospitals that have been deemed as safety net hospitals to be not well vested, not receive enough support. Their staffing is low, their ratios are low, they are inundated with patients without appropriate resources. And some of it is policies that have been in place a long time that demonstrate structural racism, particularly around segregation in healthcare settings, as well as the fact that, as I said, women aren't heard, and women of color in particular are not listened to. And again, it's not intentional. But it is unconscious bias, and it does affect people's outcomes. So again, finding the allies to help us recognize all of these elements, work together, and to provide the resources necessary to address each part of it is really important. So that's another, I think, opportunity we have for the advocacy.
I think we have to improve the science too, because everything you said about the major issues that are in the Black community when it comes to infant mortality, Hispanics face those kinds of uh, issues in how the system treats them, the lack of care, lack of prenatal care, lack of access to health insurance. People don't speak the language, but our birth outcomes are much better. So I think part of it is we're missing what is going on in the Black community, and how can we support Black women. And I think part of it is the science behind, uh, infant mortality. We have to look closer at that and see what's going on. For decades, we know that regardless of income, Black women have higher rates of infant mortality. And while we can change the structure and the systems to some degree, I don't think we can do that as quickly as I'd like. But anyway, we really have to answer other questions about what is going on with Black women, that we find this consistent pattern and we need to change it.
Yeah, I think you bring up such a good point. And I think that it's really important that we fund organizations that are often we don't get good data about community level interventions, because funding has been more directed towards basic science interventions. And so the opportunity to have funding working with community organizations that are based on hearing from the communities most effective, I think is really important to then look at what kinds of outcomes can be demonstrated in just a couple of studies that have shown outcomes. We're looking at Black women birthing people whose obstetricians are also Black women, have a dramatically improved infant outcome, a fourfold lower infant mortality than Black women cared for by white physicians. And so trying to understand what's behind those numbers are really going to be important, and have to be understood by also then looking at outcomes of women cared for, through their healthcare teams of choice. And what I mean by that is access to non-physician care teams such as midwives, and opportunities for support through programs like the doula programs or community health workers. And so I think it's an exciting opportunity, but as Jane really points out, the research and the funding behind these programs and the data to support how we can demonstrate outcomes, I think is really.
And also look at good models. Why are Hispanic women having healthier birth outcomes? Low income, less education, low insurance, and obviously very few Hispanic physicians. So it's not like they're being, culturally appropriate, even fewer who speak Spanish. We really need to understand what is causing these kinds of differences and see how we can elevate people so everyone has good health outcomes. One of the things that concerns me is very often when we look at data and we compare it to non-Hispanic whites, like non-Hispanic white women, and that should be the goal. Well, no, the goal should be better than the best. So if Asian and Hispanic women are having great birth outcomes, then everyone, non-Hispanic white women, non-Hispanic black women, should have birth outcomes like that. So that should be the goal. Rather than comparing one community against another, just who's doing really good in this area. And let's find out what they're doing good. And let's give that good information to both the system and to the people so everyone can be on the same page to try to make health better for everybody.
I think it's such a poignant statement, but yet so accurate, right? To be able to share that information, that vital information to all of the communities and rise all of the communities, right? As opposed to just a single community. Where do you think that there could be an alliance with maybe pharmaceutical companies to help in this shaping of the data research? Is that a possibility in your opinion?
Well, I think one of the opportunities that's really important is there needs to be initiatives and requirements. So, and what I'm thinking of specifically is the requirements that when there are research programs that are funded, they should have representative populations. So what I mean by that is that they aren't only representing certain populations. And historically, as Jane points out, the populations represented aren't representative of women, aren't representative of people of different ages, aren't representative. Pregnant women are almost always excluded from every study about any new pharmaceutical agent, as well as women of different identities. And so when there is incentive for that funding or a requirement for it, such as NIH studies that aren't moving forward, that they need to have representative populations, they will find representative populations. But often that research, pharmaceutical funded research, hasn't had that representation, even though there are, there are many examples that would say that would not follow that rule, but in general, that would be true.
And I think that people, I hate to be harsh, but we have to make an economic argument. And the economic argument is that if you come up with a new product as a pharmaceutical company, we know that's really expensive to do. However, you want your product to succeed. And if it doesn't, and if it succeeds only with some communities, you want to know who it's going to work for. And you don't want your product thrown out after you've done all these clinical trials, because in the big scope of things, it doesn't seem to help. So getting information by community, by subgroup is very helpful. And gender information is essential. The fact that in 2024, I still have to talk about the need for data about women in heart disease, in other studies of cancer besides breast and cervical, is ridiculous. But it is where we are. So part of it is an economic argument. And we have to say, if you want to make money in your new product, you better have representation in your trials, because otherwise, forget what the FDA says, you're not going to get your money back, because if when your product comes out, you start hurting people, it's going to be pulled. So I think part of it is being very, saying, this is not just good because it's good. This is good science. This is good business. It is the right thing to do.
Yeah. You mentioned that this is the state of affairs in 2024, right? And it's still staggering. Let's close with your thoughts that you can share with the listeners about your vision for, women's healthcare in the next 5 years.
Well, I'm very hopeful. I think that more and more women, especially younger women, are getting involved in their health. I think healthcare is changing, and I know that Jody mentioned that we don't have enough primary care providers. I think what we define as primary care is going to be changing, because a lot of that is going to be done in home. and it's going to be done in a very different way. I mean, I remember a time when if a woman wanted to know if she was pregnant, the thing was, well, did the rabbit die? Because that was the only way. But now women can find out if they're fertile at home. So I think care is changing, and we have to make sure that as our healthcare knowledge changes, we bring women with it, that we include women, train women, inform women that there's a new way to do things. And we will be part of that change.
I agree wholeheartedly. Jody, what do you think in the next 5 years
I'm
for you?
slightly less optimistic than Jane. I will admit that. I'm not without hope, but there is a reproductive health crisis right now in America with this big division across the country and women's access to health resources they need to achieve their reproductive goals, whatever those are. Because reproductive justice is about every person having access to the kind of family they want, how big it will be, whether they'll have children at all, but to be able to achieve the health outcomes that is desired by them. And we are moving away from that for women in many parts of the country. I am hopeful, as Jane said, that we have a young community of people, both men and women, boys and girls. And I think that we can be hopeful that there are creative uses of social media, it's a tool. It can be used for good or for ill. But I think there are many opportunities that they are using to educate themselves and others about the opportunities for best health practices and that empowerment. And so I am hopeful that we will be able to reverse these negative outcomes back to improvement, because we have the knowledge and the vision in this country and the people to help us do it. And the people are, all of us. And the dream and desire for healthy families is one that is shared by everyone. And I think that, as Jane said, we need to expand our vision of where and how you can help fulfill that vision more to the home, to the family, and to the larger communities, and invest in those resources and ways to do so.
Well, I hope that the future brings us much progress. And I'm hopeful that with you both in the positions that you're in, that you'll help navigate those waters for us and provide the mentorship that many other individuals and women need to be able to take that role and carry it themselves. With that, I'd like to thank you for joining us today. It's been wonderful talking to you about these important topics. And Jane and Jody, we really appreciate your time. There might be a part 2.
And we should talk about AI at that point, and the promise that it has, because I see it as having a lot of promise, but it has to learn about women. We're not there, and some of the stuff that it comes out with is like, what? So I think that there's a lot. I mean, I'm hopeful.
We'll make that the next topic of our next episode will be on AI and women. Thanks very much for joining us today. Listeners, thanks very much. For more episodes, just please go to your favorite podcast streaming platform and access your Hear From Her episodes. Thanks, everybody. Have a good one.
Thanks for joining us. Tune in next week as we continue our journey to amplify the voices of women leaders in pharma and medicine. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next week, remember to lift as you rise.